Indeterminate ultrasound in pediatric appendicitis is prevalent, poorly documented, and predicts additional imaging. My name is Maura Olcese, and I'm a pediatric resident at Kaiser Oakland Medical Center, and this study was done in conjunction with the CREST Network, or the Clinical Research on Emergency Services and Treatments, within the Kaiser Division of Research. I have no actual or potential conflicts of interest in relation to this presentation. Before we get started, a little background on the Pediatric Appendicitis Risk Calculator, or the pARC score. This is a recently developed and validated clinical calculator used to quantify risk for appendicitis on a continuous scale for pediatric patients presenting with acute abdominal pain. Variables used in this calculator include age, sex, white blood cell and neutrophil count, pain duration, pain with walking, abdominal guarding, migration to and maximal tenderness in the right lower quadrant, and it's been found to reliably delineate patients at very low or high risk for appendicitis, with the highest risk, or a pARC score over 85%, being 99.7% specific for appendicitis, and the high indeterminate, or pARC score over 75 to 84%, being 97.5% specific. So the Pediatric Appendicitis Risk Calculator can quantify the risk of appendicitis in pediatric patients and may also guide diagnostic imaging, such as a focused abdominal ultrasound. However, many ultrasounds are read as indeterminate and equivocal. So for our study, we sought to examine the association between the pARC score and an equivocal ultrasound report for pediatric appendicitis. This was done as a subset of a larger multi-center prospective cohort study using 394 patients ages 5 through 21 years old presenting to 11 Kaiser Northern California emergency departments with less than 5 days of right-sided or diffuse abdominal pain over the course of January 2016 to December 2018, and who also had an abdominal ultrasound obtained. Variables that we used include the ultrasound report as negative, positive, or equivocal, with equivocal being defined as non-visualization of the appendix, and further subcategories were based on notation of secondary signs of inflammation, and then whether a follow-up intervention or further imaging was obtained. We then used multivariate logistic regression, adjusting for multiple patient and facility level predictors to examine the association between pARC score and likelihood of an indeterminate report. We found that pARC scores over 85% were more likely to have positive ultrasound findings and significantly lower odds of an indeterminate ultrasound report, with an odds ratio of 0.08. We also found that the majority of ultrasound reports, so 89%, were equivocal, and while this varied across facilities ranging from 71% to 100%, this was very surprising. Only 26% of equivocal ultrasounds reported secondary signs, and documentation for this was even limited and variable, with 13% documenting free fluid, 7% enlarged lymph nodes, 5% peristalsis, and only 1% documenting lower quadrant tenderness. Among patients with an equivocal ultrasound, patients with secondary signs of inflammation had a higher rate of subsequent CT imaging compared to those with no secondary signs reported, whether this was because they were not present or not documented. So in conclusion, yes, pARC scores in the highest risk category may predict the likelihood of a positive ultrasound report. But more importantly, the vast majority of ultrasound reports for pediatric abdominal pain in our community ED system were equivocal, and this likely contributes to unnecessary testing and interventions. Opportunities exist to improve and standardize ultrasound reporting to aid in diagnosis of appendicitis, and I'm pleased to report that quality improvement efforts in standardizing reports are currently underway, so more to come in the future. Thank you.